welcome. Good afternoon. My name is Kelsey Goforth, and I'm DWDC's Director of Programs, and I'm joined by my colleagues Amanda and Taylor. And before we get started today, I'd like to acknowledge that the land that we gather on is the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, the Métis, and the Mississaugas of the Credit First Nation. These nations continue to experience ongoing colonization and displacement, and today Toronto is covered under Treaty Number 13 and the Williams Treaty. Dying with Dignity Canada is also mindful of broken treaties that occurred across Turtle Island and recognize our responsibilities as treaty people to engage in a continuous process of truth and reconciliation with all peoples across this land. I'm thrilled to welcome you today to this session. And as a reminder, through our webinars, we aim to provide you with information and key takeaways, as well as create a space for conversation on end-of-life issues alongside the professionals that know it best. And today's session in particular is one of our spotlight series on individuals working in the end-of-life space and how they can provide their supports to individuals navigating end-of-life and their families and loved ones as well. So before we speak about our guests today and share a little bit about who they are, I'd like to go over some housekeeping items with you. Everyone that's on the call today is muted. However, there are opportunities for you to submit your questions. To do that, you can type your questions into the question bar on the Zoom side panel, and we'll read it out for you at the end. We do have quite a few people joining us today, which is excellent, but to try to get to as many questions as we possibly can, please try to keep those questions as clear and concise as possible. And if we don't get to everybody today, you are welcome to email us at support@dyingwithdignity.ca. And further, if you have questions that are more personal in nature and not something that would be addressed through a public webinar, you're also welcome to reach out to us through support@dyingwithdignity.ca for those questions too. We're also recording the session today, so if there's anything you want to rewatch, it will be available on our website in the next couple weeks. Like always, we do have a survey that will pop up after the session as well. If you have any feedback for us about the session, we would love that, and we love any ideas you have for future webinars as well. Furthermore, if you're not already on our email list, there's lots of regular updates that go out from us, and that's the best place to sign up if you are interested in other webinars that we have, events, advocacy initiatives, all things related to our work. That is the best place to go to get that info. And now I'm going to introduce our speakers joining us today. So we have Shelley Aronoff, a social worker and MAID coordinator with over 25 years of healthcare experience, specializing in oncology, emergency medicine, and end-of-life care. She currently works in the emergency department at Humber River Hospital, where she advocates for patients, educates staff, and develops programs to enhance care. At HRH, which is Humber River Hospital, as the first MAID coordinator there, Shelley helped establish the hospital's MAID program, integrating it into patient care through policy development, staff training, and emotional support for patients and families. She is dedicated to ensuring that individuals receive care aligned with their values, both in life and at the end of it. Outside of work, she enjoys cooking, traveling, and spending time with her family and friends. Welcome, Shelley. Great to have you.
Thank you so much. That's a great, that's a wonderful introduction. Thank you. And you basically summed up my role.
Perfect. Well, we look forward to learning more as the session goes on.
Thank you.
And next up, we have Courtney Matthews. Courtney is a mental health clinician and clinical coordinator at a Medical Assistance in Dying Care Coordination Center in British Columbia. She supports clients and their families through the MAID process, providing collaborative, patient-centered care to honor their end-of-life wishes. With 10 years of experience as a social worker in healthcare, Courtney's work prior to MAID includes inpatient psychiatry, community mental health, chronic disease management, and acute care. And outside of her social work practice, Courtney enjoys exploring the beautiful BC mountains, lakes, and ocean with her partner and dogs, camera in hand. And thank you for joining us today, Courtney.
Thank you for that introduction, Kelsey.
No problem. And finally, we have Annette Sampson. Annette has studied social work at both Dalhousie and McGill University and is currently employed with Nova Scotia's MAID team. She has worked in healthcare social work for 18 years. Her experience includes working with seniors and homeless and at-risk women and youth in Nova Scotia, Quebec, and Ontario. Working in healthcare has ignited a passion for grief and bereavement work, and Annette considers herself a grateful recipient of the wisdom and knowledge imparted to her by her clients. Born off the island of Cape Breton and now living in Halifax, Annette enjoys urban gardening and wild swimming whenever and wherever she can. So thank you so much to all three of you for being here today. We're so glad to have you. And I'm going to hand it over to Amanda to get us started with the interview today.
All right. Thanks so much, Kelsey. And thank you so much to our panel for joining us here today. So without further ado, let's go ahead and jump in. So we have a series of interview questions for everybody here today. And in the interest of expediency, I think we'll just sort of go in a round. So I'll just pick somebody to answer, and anybody who wants to jump in, feel free to start. Okay, so let's go ahead and start with Annette, for example. Can you tell us a little bit about why you decided to pursue social work, and again, a little bit more about the populations, the communities that you've served in those 18 years?
Sure. I guess you could say that I've been from a family, I come from a long line of helpers. And from the time that I was very young, my grandfather was one of the originators of the Annie Gnish movement, which is part of now I think it's part of the Coady Institute. Well, it once was, or the precursor of the Coady Institute at St. Francis Xavier University. And I grew up on a small island off the coast of Cape Breton. And around my table, there were my grandfather or my dad was helping people do their taxes, people who had very limited understanding of reading and writing. And my grandfather was part of bringing literacy to communities of farmers and fishers and coal miners in Cape Breton. And so that has been a big part of my life, and I met lots of social workers growing up. My parents were part of the co-op movement and the CCF party, which that wasn't yesterday. And so I met lots of social workers and community members and community builders and helpers all of my life. So that kind of helping has always been an attractive thing to me, and why I decided mostly that I wanted to pursue social work. So I started off working with in large communities, so very much community focused. While I was working summers, I would do that, and then proceeded. I think my first social work jobs were in working with homeless and at-risk youth, as well as women who were experiencing alcohol and drug misuse, as well as street involvement. And so that's sort of how I started. And then also, oddly enough, worked with kids who were in a ballet school as a counselor for them as well. And that kind of evolved into working with seniors mental health in Quebec and in Toronto. And following my experience in Montreal, I decided that I wanted to become involved in healthcare social work, which is, of course, a different animal than all the other community based stuff that I was doing. So yeah, that's sort of how I came to want to become a social worker, and that is how my social work career has evolved from community work to healthcare work. And now with MAID, I've been on the Nova Scotia MAID team now for about 2 years. And it's been an amazing time to help people at this point in their lives when, everything, the world becomes small for them and very focused. And it's been super helpful and I feel very grateful to be working with this team.
Yeah, Absolutely. I love how you described it as you come from a long line of helpers. I love that. Thank
Mm.
you. Okay, Courtney, next up. So, same question. Tell us a little bit about why you decided to pursue social work and the kinds of populations and communities that you've served.
hmm Thanks so much, Amanda. And Annette, I really liked hearing your story and where you've come from as well. I think like coming from a line of helpers and recognizing the impact in your communities, I think social workers have a lot of history of why we get to where we are. So I grew up in a small community in Kamloops, BC, and my mom was actually, she still is, she's a care aide in that community. And so I felt coming from a small community, right, with Kamloops, that it's not a very resource rich city. And I really recognized how the social determinants of health really impacted health outcomes and seeing the kind of situations my mom would be crying about when she'd come home. Um, it made me sad to think, okay, how can I be involved in help, but in a different way? And so I was actually recommended the social work program as I really wanted to go into counseling. Having, I'm sorry, my dog is crying. Um, having having seen a lot of trauma within my family and my social circle, I really wanted to help in that way. And so social work was a really great way to bring like the biopsychosocial elements that I've come to know from my mom working in healthcare and the kind of emotional work I really wanted to do. So Thompson Rivers University was actually where I got my bachelor's of social work degree. It was a fabulous program that helped me actually understand and see the power of nonprofit community, like nonprofit organizations in communities helping each other, and how vulnerable populations can be empowered to speak up and have their needs met. So it was actually quite beautiful and eye-opening to see that, I'm thinking, oh, Kamloops doesn't really have a lot. And while it may not have as much of the funding and resources as bigger cities do, they were able to work together with what they had with people who were really determined to rise up. And I just found that really empowering and beautiful. So that's kind of where I started in social work. And I then um, worked in Hillside Tertiary, which is a inpatient tertiary psych center in Kamloops. That's where I started working in healthcare, and I thought it was fascinating to see how regionally people would come together to support clients and patients and loved ones with really complex um, mental illnesses and other medical comorbidities. So that I went from working in nonprofits and working with unhoused populations in Kamloops to then working in healthcare. So from that point, I did end up moving to Vancouver, which like blew my mind, honestly, in Vancouver, British Columbia. It's a very, very big city with a lot of pockets of people. And it was shocking to me because I went from Kamloops as being small, under-resourced, but big community to a large city with many pockets and people kind of falling through the cracks. So you sort of see the benefits of, oh, we have more funding and support, but we don't have as much of a tight-knit community. So it's interesting to see how regionally that was different. But from that point, I worked in inpatient psychiatry in Fraser Health in the Lower Mainland. I had then worked in community mental health, so seeing the differences between how those systems function. Then chronic disease management and chronic kidney disease. I started to see a lot more end of life with people on dialysis and deciding to stop dialysis or passing before that. And that is actually what got my interest into acute care, seeing a lot more death and end of life. And I then actually since 2022 have been working within the MAID Care Coordination Center, and it's not the direction I thought I was going to go, actually, in my social work career. I thought I was going to be mostly working in nonprofit and community. And I think, um, like Annette was saying, all these different experiences kind of guide us to where we are going in our path and what actually we're passionate about. And this right now has been probably the most rewarding and honorable work that I've done is working in end of life care and supporting people to have a dignified end of life and have choice there. So yeah, that's a little bit about my story and where I've come from. And I'm really honored to be here and talk amongst these other lovely social workers today. So thank you.
Yes, here. And interesting to hear from the both of you, starting more in the community
Mhm.
social work space, but moving over gradually into healthcare. So very interesting. Okay, last but not least, Shelley, same question, a little bit about why you decided to pursue social work, and the populations, communities that you've served.
Yeah. So thank you for that. And it's really nice to hear that both Annette and Courtney have the community aspect of it, whereas I have always been in healthcare. Other than my learning, my bachelor's degree, my master's degree, we've had to do some placements. I had community exposure there. But certainly working kind of, frontline, it's always been in healthcare, and that truthfully has been the passion of my life. But when people have asked me all the time, what made you go into social work? A quick, funny, it's not really funny, but I've actually always wanted to be a veterinarian. But because I was never great in math or science, I thought social work is it. For me, though, social work means I found that I just have a love of being with people. As the years have kind of transcended into now me 26 years, specifically working with counseling, crisis support, I feel I've become so intuitive that almost being empathic with somebody in the moment and their needs, it's like second nature to me. But I've always just really had a love of people. And as I started to go to school, and my family are immigrants, so knowing and seeing that maybe they can't express themselves in ways that they would have wanted to in many ways. They didn't have advocates for healthcare. They didn't know how to even navigate the system. I realized people need this. People need advocates. People need um, someone to listen, but and hear what we have. So by the way, we are at Humber. We are one of the largest emergency rooms in this city, emergency departments in this city. Um, we have an incredibly diverse both staff and patient care population. Literally, I think we serve like 152 languages.
Wow.
And because of that, we even have language lines instituted 24/7 available to us, and which I love because you're getting it from the patient and you're not using their family as interpreters, which can make things, as you can imagine, incredibly uncomfortable in so many ways. So we do have a diverse population with all sorts of different needs. But just a little, I know I'm kind of going all over the place. There's so much to say, like my head is like, full of these things I want to say, and how do I condense it all? So just to say that I've had the education for being in hospitals. Specifically, you have to have a master's of social work. So I'm happy to say I have both a bachelor's of social work and a master's, and you have to also have a registration. I know that part of the question was what education is required. So you have to have a registration of social work as well.
Yeah.
And I've always, so I, even in my student placement, I fell in love with the emergency. And that was where I was initially placed as a student, and then ran with it from there for about 17, 18 years. Actually, maybe 17 years. And then from there, I transitioned to oncology. And people would say to me, why are you leaving? It's so depressing. You're going to be working with death and dying. And I thought, well, let's try it. I mean, it was a completely foreign concept for me. Just the specialty in oncology and palliative care and how we help people die. And I've always said, a part of me, I help people live, but a part of me, I help people die. And I think it's one of the most beautiful things that you could do for someone at the end of life is how to bring them to that space and place that's honorable and that creates a legacy for them. So it was during oncology that, and this is before MAID, became legalized. I was privileged and bared witness to active deaths or active process of dying, where patients would say to me, please, I'm in agony, is there anything you can do? And watching it and just being so present for it was actually heartbreaking. And especially so during COVID. COVID, I think, was probably the hardest times for me morally and ethically, where we had to keep their families and loved ones away and when they were dying alone. It was really, really difficult. And you can imagine that requests for MAID were certainly my hospital on the rise back then because they felt so alone. So that kind of made me fall in love. I know it sounds odd to some people, but maybe not to this group. That death and dying has become working with death and dying has become quite a passion for me. I'm back in the emergency now, where we see everything and anything you can imagine, from traumas to housing, from child protection, domestic violence, sexual assault, housing, immigration, financial issues. And on top of that, all the traumas that come in. So all the sudden deaths, or even people that were palliative at home and their families brought them in saying, do everything, when they're literally have less than a month to live. So navigating goals of care and, and end of life. And we've even had people intubated and extubated from the emergency department with loving and supporting conversations from none other than social work. So that's, and please ask any questions. I could be missing so much, but ask away.
Okay. All right. Thank you so much, Shelley. Okay, let's go to Annette for our next question. So, Annette, can you share a little bit about some of the day-to-day responsibilities that you have supporting patients and their families? What type of practical support can a social worker offer for somebody that's receiving end-of-life care? Oh, and Annette, you're just on mute.
Thank you. So the beauty of social work is that we can work in healthcare, but we're not the healthcare provider in many ways. So one of the things that social work can do is sort of almost act as funny as Shelley was talking about translation services. As social workers, we kind of translate the language of medicalese to clients and their families, because the healthcare world is a very medical world, and it has its own language. And so that's one thing that social workers can help with. And the interesting part about social work is that it's a very general a kind of helper. That's why I use the word helper, because social work is very general. And so we help folks in many different ways. And we help people contemplate at the end of life what that means existentially for them. So at the end of our lives, we all come to certain points and think to ourselves, what have I done? What have I done? And what does life mean? What does it mean for me now that it is ending? So we have those big conversations, and we're privileged to have those big conversations with patients. So I would say that is like a very general but a big thing that we do. And typically we get all sorts of kind of roles that we're asked to especially in hospital. We joke sometimes that when you don't know who is supposed to help with this particular problem or concern, call the social worker. And so that happens a lot in healthcare. I'm not sure what I need to be doing here. I'm not sure how we should approach this. Let's call the problem solver. So sometimes that's what social work is for folks in healthcare. We're the problem solvers and the translators, and we help people with existential thoughts and ideas, and end of life is around that. Now, when we talk about social workers helping with people at end of life, some of that is looking at personal directives and what is acceptable to me at the end of my life. What makes sense for me, for my values as an individual, and my hope for my family and for my future. So we look at personal directives and we help explain what that means because that's another medicalese kind of term. And sometimes at intake, people would say, "Do you have personal directives?" And so this patient would go, "Yeah, sure." Or I'm not sure what that means. And so another way that we can help is sort of simplify some of those concepts and help people understand what they need and where they're kind of going in terms of end of life care. Yeah, I think that's most of what I wanted to say about that. But if I have
Yeah.
any questions, let me know.
Yeah, thank you. I think that's a great way to put it about translators or problem solvers. So sort of that hero, if you will, when everything else fails, call the social worker. So I love that. So Courtney, same question for you. Can you share a little bit about some of the day-to-day responsibilities you have supporting patients and their families? What kind of practical support can folks expect from a social worker at end of life?
Yeah, sure. Thanks, Amanda. And Annette, I'm so grateful to hear that throughout the country that we are all sort of seen as those problem solvers. And you get such interesting referrals sometimes when we have to work outside the scope of what's medically being completed and supported and what we're doing as social workers. So I can provide a little bit of information around practical end of life support that we provide. As a coordinator within the MAID program in Fraser Health in BC, we work closely with palliative care social workers as well. So if a client is not connected with a palliative care social worker, we do a lot of this other support. So I can just briefly talk about that.
Hmm.
Um, One of the things that palliative care social workers really like to talk about, and just like you were saying, Annette, is like that what is meaningful and important at that person's end of life, who they want there, what they want to happen. Social workers can help support with legacy work to ensure that somebody's wishes are fulfilled at the end of life and honored at the end of life, and their family can and their loved ones can continue on that legacy. We also help to provide a voice for patients and their loved ones around what they want that to look like, whether that be end of life rituals, that could be spiritually, culturally, um, referring to appropriate community members in that regard. So whether that be religious leaders or elders or people that are really important to that patient to be there. And practically, we talk about navigating end of life arrangements. So that could be, does that person have a will? Like, who's the executor of your will? Have you talked about what you want that to look like? Um, we can't, and I know there's a question later around what we can and can't do as social workers, but we can't legally sign documents like a will or a power of attorney, things like that, at least not in British Columbia. But we can at least have those conversations and help with you have your funeral arrangements made. Do you have a cremation? Like, what do you want at the end of your life? And then being able to talk about that in a, sort of advanced care planning, it can allow the patient and their loved ones to feel a little bit more at ease of, okay, I know what to expect. I know what I want, and I can actually spend this time with my loved ones without worrying so much about those practical things because there is a lot that happens leading up to death. And I know a lot of people don't want to think about that, but it is really important, especially when we're in my work, when we're actually planning a death. People do need to have those plans in place. We can also talk about the practical steps following somebody's death. So what happens? What's the role of the executor? What is it that you need to expect and understand? When do you call the funeral home or the cremation provider? Um, what does the death record look like? You know what I mean? Like what goes to vital stats? What is that? So we can help answer those questions that can be sort of gray or misinformation on the internet. And then leading up, we can talk a little bit and support the family and patients around that anticipatory grief and bereavement support following a passing. Within my work, I don't have the capacity to do post-bereavement support and care. I know some communities do have that resource available, but we don't. So we often lean on the palliative care social workers in the community, or we refer to hospice societies or other agencies that are available to provide that bereavement support. And then, I mean, like wrapping it all up, I think social workers practically we're system navigators and we're trying to help explain things in terms that are easy for patients and loved ones to understand. And we want to make this process as peaceful as possible and help them navigate that. So those are some practical things I think you can expect from social workers.
Yeah, absolutely. Shelley, same question. Can you share a little bit about your day-to-day responsibilities that you have when supporting patients and their loved ones? And then, again, what kind of practical support could someone expect from a social worker at HRH?
So definitely both Annette and Courtney nailed it on the head when they said generalists, because we truly are. Well, while in the emergency, let's say, or in the hospital, we have specialists for mental health and geriatrics and all sorts of different specialties. But the social worker can pretty much do it all. And having said that, they often think that we would have this magic wand in the back of our pocket just to make issues go away. But things that we're dealing with on a day-to-day, and I just made some notes so I don't forget, would be people's, for instance, housing status, changes in their function. If they're hospitalized, all of a sudden they're not able to walk, or they have different needs, or they have oxygen at home. So as Courtney was saying, even just assisting with practical needs of setting up equipment at home, transportation, who's going to be providing groceries, just eat, like literally the ADLs, we call it, the activities of daily living that we take for granted. Really, hospitalizations really change things for people, and that's if they're going home. It becomes a lot more intense when they're going home to die. But I'm going to park that for a moment. But we do address things like family dynamics, right? So this is for people who are generally, whether they're coming in and out of hospital or they're in the actual processes of dying. Access to services and ensuring that they're equitable and fair and they're accessible. We provide often a lot of crisis support, and counseling. We facilitate psychosocial assessments, and part of that is truly trying to tease out what people's needs are. Because to do a great intervention, you have to establish what the need of the patient or family is. And once you can kind of hone in on that, the interventions, follow suit. And really, we are an integral part of a multidisciplinary team. I mean, I talk about, yes, we do it all, but we don't. We do it in tandem with physiotherapy, occupational therapy. We have ethics, we have chaplaincy. So if there are issues, we're not really truly alone. Although I could speak from the hospital side, we are considered patient navigators and patient case managers. So we pretty much are it in terms of their admission and discharge. However, we do work very closely with the allied team and the physician staff as well. When it comes to end of life, obviously, again, we continue to review their needs. And when I say their needs, both patient and family. So I work with them together and separate, again, depending on what the situation, what types of situations we have. So communication is essential and ongoing at that. We address, I think, the two social workers touched on ensuring that they have their affairs in order. There is so much distress, especially if it's a surprise death, meaning that they didn't realize that the death was going to come so soon. And they're they're very anxious. They're very stressed about, I haven't done this. And a few of them a few times we even issued day passes. And we have, in terms of even transportation, ambulances, just ensure that they're home to make things happen for themselves. And then oftentimes we ensure that they can come back to hospital. So there's a lot of behind the work, intricate things that we do that on the outside seem effortless. Well, we make it kind of look effortless, but there's a lot of little phone calls and again, case management that happens. We encourage connection and closure. And this happens one-on-one with, let's say, patient and myself, and patient and their family. A lot of the times there is poor dynamics that were never addressed. And having the time to die, I always say when it's not a sudden death, the luxury of that is having time for closure. And maybe, time to speak with people that you haven't spoken with, or again, put your affairs in order. So I always try to reframe that there's a lot of positive aspects to having time to die, or having a scheduled, let's say in the case of MAID, having a scheduled time to die so you know when things are happening, and that person is in control or has more control of facilitating things that are meaningful for them.
Yeah.
Yeah, and just again, doing a lot of narrative therapy and life in review. We do that a lot as well. Again, I can go on, but in the interest of time.
Yeah. Well, like I said, we're just trying to get a snapshot of everybody's work today. I know we could do a full year-long series
Yeah.
on the work of social workers. So moving on for our next question, maybe Courtney, we'll start with you this time. So when should a patient consider requesting the support of a social worker? Let's assume in this case, perhaps they don't have one assigned to them as of yet, or they're taking a look at their end of life plans, the type of treatments they do or do not want. When should somebody be considering the help of a social worker?
That's a really good question. It depends where they are located too. So if somebody is in the community and they're not connected to, this is also speaking specifically within British Columbia, in Canada, well, we're all in Canada, but in British Columbia, if somebody's in the community and they're not connected to anybody, and they're having, you know, any kind of difficult financially, I think financially things come up quite a bit. Um, they're wanting some system navigation and resources. They're not sure where to go. We do have primary care clinics within our health authorities, and somebody can actually request to speak with a social worker at a primary care clinic. Now, those resources are very limited, so it's not, you don't need a physician's referral to attend them, but it may be a while before you can be seen by a social worker. But so social workers in primary care can help with, you know, supportive counseling, system navigation, financial resources and support, advanced care planning as well. And throughout all that, I think the family dynamics are can be quite significant, and oftentimes social workers are involved when there are complicated family dynamics, like Shelley's also expressed. Um, where you most commonly see people being supported by social workers is when they're actually in the hospital. Many people don't come across a social worker until they're in the hospital. They might not even know what we do. They might say, "Oh, well, I don't have any children, so I don't think I need your help." Because social worker in the media is often considered to be those within our ministry here, child welfare social workers, or with the Ministry of Child and Family Development in BC. But we support with a lot of different things in the hospital, and anybody that's struggling with, say, the anticipatory grief or maybe a sudden loss of a loved one in the hospital can request to see a social worker. Again, having those practical concerns of what kind of supports am I going to need when I go home, or am I going to be needing a higher level of care? Social workers are often involved in that. Um, Anything, again, financially comes up quite a bit, housing comes up quite a bit, but that does not necessarily mean that we can expedite somebody's access to housing resources, but we can at least provide them the resources that are available. Um, Oftentimes, people who are in the hospital more often, or they're familiar with the healthcare system, actually request social worker support because they recognize the value that we provide. But patients themselves can request to see a social worker, and the nurse can put in a referral for us. Or, like Annette has also said before, sometimes the healthcare team, the multidisciplinary team, will recognize that there's a problem they're not really quite sure how to solve, and we will get referred. And that can be when we meet with the patient, they say, "What are you doing here?" Um, our involvement in healthcare is voluntary. So I always try to remind patients and loved ones of that, as we are not there to impose our values or beliefs on anybody. We're here to try and support you and navigate that with you. We're not here to give you advice, but we can help you kind of navigate some of the concerns that you have going on. So yeah, in hospital, oftentimes we're referred or the patients will ask us directly, but in community, it is a little bit more difficult. But primary care social workers are a great resource and a hub of information if people in the community are not really sure where to go, or they're having a difficult time and they need help navigating the system. So it's a very
Thank you.
big question,
Yes.
but that's the best way I could answer that.
Well,
Yeah.
it was answered very well. Thank you. Annette, same question for you. In your opinion, when should a patient consider requesting the support of a social worker?
Um, I often say to people, because I don't work in hospital anymore, I kind of am working in MAID, but in community. Um, I usually say to folks when you're or discuss with people when you're feeling overwhelmed, when you don't know where to start, when you're grieving some losses of your own as someone who is seeking aid, this is a good time to ask for a social worker. For me, oftentimes I hear people say, "This is what I'm thinking about. I don't know what to say to my family or how to say it. I think they're going to think X, X, X about me. I I've been hiding my illness from my family for years. They think I'm just fine. And now this is going to seem out of the blue to them. So when people are grieving the end of their life, when they're grieving and when they're worried about what to do, they don't know where to start, practically and emotionally, this is a good time to ask a social worker to help. I recognize that I'm very lucky in that I work in this kind of situation where I can provide uh, um, some support to families, whereas a social worker in hospital might have lots of competing uh, needs at for their attention. And so, having done that on a stroke unit for many years, I understand that that can be difficult. But if a social worker doesn't know how to help you, they will send you the help that you need somehow. And so at any point, I'd say when a patient feels that they're at an impasse, this is a good time for a social worker. And some of that um, like we can't solve all problems, but what we can do is we can steer people in the right direction. We can get people to prioritize their needs. We can help them prioritize. So these are all kind of practical ways that we can help folks. And we can also say to families, again, getting back to the translation idea, this is how your loved one is feeling. And why don't we talk about that? We can initiate conversations that are really difficult. Some of these conversations are really hard. Some people haven't had any conversations with their family for many, many years. And so this is a way that you can request social work. You can here in Nova Scotia, you can self-refer to social work in MAID. You can call our MAID line and say, I need to speak with a social worker, and we will speak with you. And so there is that. And but generally we get our referrals from physicians, nurse practitioners, nurses, other sort of allied health folks who notice somebody is struggling in the community. I would say it would be good to contact social work before you're struggling, but the reality is that never happens. And you keep on keeping on, and people are super resilient until they just can't do it anymore. And so this is a good time to talk to a social worker. Um, and we can liaise with your team and help other team members and support other team members and giving you the support that you need. So yeah, that's how I would say that.
Yeah. Thank you so
Oh.
much. Okay, Shelley, same question for you. We just want to make sure we get to the rest. But yeah, just want to see if there's anything you want to build on what Courtney and Annette had shared about, when should a patient consider reaching out to a social worker, especially in perhaps that hospital context?
Yeah, and you know what, I mean, the first thing that came to my mind, and both what Courtney and Annette said are actually true, so I won't repeat, because that is exactly what, we do here. We are navigators of care. Absolutely. And I think all the team know this. Many patients don't know what they don't know until they are in crisis. So usually if there is a crisis situation, but what really stands out for me is if there's issues or concerns of safety. So it could be safety going home, it could be a domestic violence, it could be a child protection, or it could just be without violence, just a patient going home with nothing and they're very vulnerable. So safety for me is huge. And not only are we navigating the emotional and the emotional aspects, but as they said, the practical aspects of ensuring that they have things like equipment and transportation and food and eyes on them, PSW supports. So we do work very, very closely with our community linkages as well. But so that's, I'm just kind of, and also when to call a social worker is when you're noticing mediation is required. So if there's opposing views from family, if there's opposing views from physician and patient. So oftentimes we become mediators when there is a crisis even amongst the team between a patient and her family. Yeah, so that's and the other thing again is also very big here is addressing goals of care. I often like to initiate it as soon as they come through the door. If they are out like either very, very old or very old and sick, or they have a very poor diagnosis and prognosis. It amazes me how very rare these discussions actually take place. So I'm actually privileged and very comfortable in having those, maybe not so frequent or common conversations amongst families and patients.
All right. Thank you both for that. I think all of your answers speak to the same point about trying to access that care before that moment of crisis comes. When you have those questions or when you don't have the answers necessarily, that might be the time to call in the support of a social worker. So thank you so much for that. Annette, let's start with you this time for our next question. What are, if any, some of the limitations to the support that social workers provide? And generally speaking, are there any misconceptions about the role of social workers in healthcare?
I would say some of the things that I've come across in my work, especially with MAID, are that we can advocate for someone to get MAID. So social workers' roles are advocates in many areas. However, with MAID, we cannot be actively advocating for you to receive a MAID provision. We can help support. We can help just guide you and talk to you about what you want, but it's definitely an individual's right to decide what they want. But whether you meet criteria or not, we can't influence people in any way around, and we don't make decisions about whether you meet criteria for MAID or not. That's kind of a big one in terms of working with people who would like to have a MAID provision. There are guidelines that we can't cross according to our colleges. So each social worker has a college that we're responsible to, that we are beholden to in a way. And that's good. It protects the public. So we can't say to people, hey, you know what, have you thought about MAID? This is a big limitation. We can't do that with folks. We can help people who want to talk about it and maybe look at their options, but we certainly don't do that. We can't do that according to our colleges. I feel all of our individual colleges across the country are similar in that way. And what we can do is sort of talk to you about that request. We can another misconception is that I know when I worked in a hospital and I worked on neurology, was that I could myself make a referral on someone's behalf to a medical assistance in dying team. And we can't do that. That's a strict limitation. We can't do that. Only a primary care physician or a nurse practitioner can make a referral to MAID. And we certainly I think Courtney touched on this earlier in that, when talking about signing paperwork and that kind of thing. We can't suggest a lawyer to folks. We can't, we can't say, hey, my cousin is this or that. Our college guidelines forbid us to give people names and numbers, but we can give people a general idea of what direction they could go in when they're seeking a lawyer for a will or a personal directive. We can help, we can support, we can guide, but we can't make a suggestion like that. Yeah. And again, there is a misconception that we can solve all problems, and that goes, and of course we can't. And we can address people's vulnerabilities, right? So if people are vulnerable in our communities, we can help guide them around housing supports. We can help guide them and refer them to other kinds of supports in the community. So we can do that, but we cannot take you and do that for you, if that makes sense.
Yes. Yep. Thank
Thanks.
you. Courtney, the same question. What are, if any, some of the limitations to the support that social workers can provide and any misconceptions about social work that stand out to you?
Thank you. And yes, I think you're right, Annette. I think our colleges are also quite similar around the legalities of what we can and can't do. I really appreciate you bringing up that point around MAID. So we can't counsel somebody to receive or not receive MAID. We also cannot determine whether or not somebody is eligible for MAID. Sometimes I will get calls from social workers, fellow social workers that are wanting to support their client, but they say, well, I don't think this person's capable and I just don't think it's an appropriate referral. And I always educate and say, it's actually not your determination because all we are doing in that regard is allowing the person the information so they can receive it and the physicians or the nurse practitioners can do that assessment to determine that eligibility. And so I think that that also creates a bit of relief for social workers to know that we are not determining that, but we are creating a door for somebody who's requesting a service. Um, Interestingly, and perhaps this is different in other provinces, but here in BC, social workers, while we can't sign wills or power of attorney or representation agreements, which are healthcare agreements here in British Columbia, we can actually sign as a witness or a proxy for a request for MAID. So social workers can do that. I think there's misconceptions here in BC that we can't, but we can support with that. Ultimately, it is the person requesting MAID that is making the formal request and wanting to send that in. So it doesn't have to come from a physician or nurse practitioner. It can be faxed from anywhere, even the patient themselves. Um, yeah, we can only work within the confines of the resources and supports we have. I think that's like you said, a common misconception is that we have this magic wand and we can fix family dynamics that have been brewing and being created over the past 30 years of somebody's life. We can't change that, but what we can do is help mediate and support and help people find the words to express what they need to and feel heard. And also just like creating that space and trying to provide that trauma-informed care. We can't we can't move somebody faster through their grief. Grief is not a linear process, and we can't stop people from hurting. I think sometimes we get these requests from patients or love, and they say, "Yeah, I don't want to tell my loved one about my illness. It's gonna cause a lot of grief and pain. I don't want to tell them about my request for MAID. I don't want to tell them about when I'm having MAID because I'm afraid that it's going to hurt them, and I don't want to do that." And so, well, ultimately losing you, they will grieve, whether you inform them or not. And so we can't impose our beliefs or values onto patients about what they should or shouldn't do, but at least helping them understand the information and outcome of decisions that they want to make and provides a safe space for them to explore the decision they want to make with that.
Thank
Mhm.
you.
Mhm.
Shelley, same question for you. What are some of the limitations, if any, that limitations to the support that social workers can provide, and any misconceptions about social workers that stand out to you? And you're on mute.
Okay, can you hear me? For me,
Yes.
I find, especially working in a very busy emergency department and having oftentimes a high caseload, it's time. A lot of, and again, I don't want to, very much what Annette and Courtney said is, I agree with all of that. That very much applies to what we do here. But the time concept is a real limitation. Many times I actually feel a bit distressed that I can't provide what people need because there's literally a lineup. And so it's literally just fracturing your time, but you sometimes feel that you didn't give somebody everything that they truly needed. And sometimes we have patients or families with outrageous requests that maybe you can't really meet. But I think Annette earlier said, if we can't help them, we will find somebody who can. And some of the misconceptions is, and one of the all-time is, oh, social workers, they just hand out Kleenex and they give them some water, in times of crisis. Well, we do a lot more than that. There's misconceptions that we're only involved in crisis, but that's not true. We are involved from the beginning of their journey to the end of their journey, whether it's in hospital until, certainly from a healthcare perspective, until they're discharged home. And even afterwards, there's a small availability for follow-up. And that's another limitation. We don't have the ability to have ongoing follow-up from the healthcare perspective. We kind of do a warm handover to our community partners for that. Often there's a misconception that our role ends when the patient dies. There is, again, some small follow-ups with families afterwards. And again, that's also connecting them to, to further bereavement groups or other supports that they may need. There's misconceptions that social workers just like secondary to the medical care, but in actuality, we're an incredible integral part of the team. To the point where many doctors won't discharge patients without our go-ahead. So they'll say, depending what the social worker says, that's when I'll discharge my patient. So they very much look to us for guidance, and that's not just the physicians, but the team in general is, as I aforementioned, we're kind of the patient navigators or case managers. So we are looked at often as, okay, what do we do? Where do they go from here? And that's pretty much, I would probably say, not to repeat what, my other colleagues have mentioned. That's what I would probably say to that question. Yeah.
Okay, thank you so much. Final question here before we move to audience Q&A, and we'll start with you, Shelley, this time. You mentioned a little bit through your answers about offering that emotional support or mediation to either the patient themselves who's actively dying or to the loved ones that are around them. I'm curious just what that emotional support looks like or what that mediation looks like from a patient perspective.
And that can look different depending on the family dynamics, right? So let's say I'm going to take the good case where there's wonderful dynamics and the family is just devastated. So the mediation can look like, especially if there's a lot of conscientious objectors within the family, which we've had to help navigate as well. And we've had cases that were extreme that we actually had to call security because the family wanted to stop the procedure, to families coming in and trying to talk their loved ones out of the procedure every day, to the point where the patient had to bar them from coming to the hospital. But it's sitting both together and separately with patients and families, and first of all having a deep understanding of what life experiences they've had with love and loss, with trials, and how they see death and dying and what they believe and their beliefs about it. So helping them kind of put an understanding and a form of closure to it. Helping them make, I think, sense of legacy work for both of what dad or mom meant to them and what that patient has, in and of themselves have what kind of mark they've left in this world, and is there anything else that they feel is left to do, whether it's writing letters, whether it's voice recordings, you know, so helping them with a holistic life plan. We've even had situations, and we do offer this, where they do celebrations of life. So before we know that a maid is occurring, we've even had families bring in champagne and music, and the night before, where they literally celebrate and they tell each other, you know, what each other has meant to them. And that, I find, creates so much meaning in saying goodbye, because it's something that they can take with them, and they can kind of have their parting words, or, you know, letters handed out. Um, Sorry, can you just again ask that question, because I may be going off topic?
No, that's okay. So, some of what it might look like for you to provide emotional support to a patient and their loved ones that are actively dying. Again, just what that support looks like, what somebody might expect.
Right, yeah, okay. So, yeah, what is, as I kind of was saying, sitting with families and patients, again, either together or separately, helping them come to an understanding of the meaning of disease, what that looks like for the body. Oftentimes, when we withdraw medical care and focus on palliation, families lose their mind and say, you have to give them IV. They're not eating, they're not drinking. You have to do blood transfusions. You have, but helping them understand what happens organically to the body. And just that communication alone, you know, with the medical team, is incredible, how their mind shifts around compassion and around what sometimes doesn't look really nice, but you're providing so much well, care and compassion to your loved one by providing other measures and withholding some. So I think just integrally helping people understand what it means to be in the process of dying and be in the process of pain.
Okay, thank you. So we're just going to move into the audience Q&A. Courtney, Annette, I just wanted to check if there's anything you wanted to tack on to Shelley's answer about, again, that emotional support we provide to someone who might be actively dying and their loved ones. Okay.
I was just going to say,
Oh,
I think,
Courtney,
Shelley, you
yeah.
did a beautiful job there. So no, I think that was beautifully said. I have nothing else to add. Thank you.
Yeah, that's well said. And also, um, you know, I think that families are very and individuals there, it can be a very highly emotional, highly intense time. And sometimes just your presence as an ear to listen is important. People feel like they need to be heard at that intense time. People feel like they need some understanding, and that is our role as healthcare workers generally, but also as social workers.
Yeah. Okay. Well, that's all of our interview questions for today. Now, we've been receiving lots of questions from our audience members, so thank you everybody for submitting these. I think what we'll do is we'll do sort of one answer, one question. But if there's anything that you guys would like to jump in with to add to that answer, feel free. And anybody who wants to answer the question, go ahead and jump in. So this audience member asks, is a doctor's referral necessary to recruit a social worker?
No. Anybody can refer from the hospital, so we don't need it. And we tell everybody, as soon as you see anybody that may be in need, or even the patient can self-refer, so you don't need a doctor's referral.
Okay. And Courtney, just checking if it's the same process in BC.
Yeah, it's the same process in BC. Like I mentioned, depending where you are, whether you're in the hospital or if you're at home, there are primary care clinics as well. And in relation to a MAID request, because my work right now is within MAID, you also don't need a doctor's or nurse practitioner's referral to begin that process as well. It's self-referred, or you can request the support of a social worker or another care provider if you're in the hospital to do that
Okay.
with you. Mm-hmm.
Thank you. And Annette, I believe you had mentioned before that Nova Scotia residents are able to self-refer to get a request for a social worker.
They can, and families can, even though families may have had a, oops, sorry, even though families may have had some, they might have lost their family member a year or so before or 2 years before, here in Nova Scotia, I can still become involved if you're needing help with grieving or you'd like to be hooked up with a grief group, because here we have specific to MAID grief groups in Nova Scotia. So there is no time limit there.
Okay. Thank you so much. Next audience member question. This person asks, how do we locate a social worker, especially if we're not already in hospital, we're in the community, and again, could be located somewhere where there's an abundance of resources available or not. And there's a bit of difficulty there. Are there any options out there for each of sort of the provinces that you represent? Anybody feel free to jump in.
I can take, oh, sorry, Shelley.
Oh, no, it's okay, go ahead, because I was thinking.
Here in Nova Scotia, at least we have community social workers that are kind of navigators in the community. So we have little community help in small communities peppered throughout Nova Scotia. The other thing is, if you're in the city, Dalhousie has its own kind of social work clinic, and they help people with all sorts of concerns. I've gotten calls from the Dallas social work clinic and that kind of thing, and also referred to the social work clinic. So there is that. But here, there is a general phone number that you can call, and a social worker could be assigned to you.
Okay.
Yeah.
Courtney, just want to check if you had a response for BC. I know you'd already mentioned those clinics.
Yeah, I was just going to say those clinics, they are funded by the health authority, so it's not, so social workers aren't, they're publicly funded. That's what I'm trying to say, which is lovely. Sometimes social workers also support with private practice. So if you look up like social worker counseling services, there are social workers that do private practice, and they are often covered under health insurances as well, or extended health benefits. Um, and then again, in relation to MAID specifically, every health authority in BC has a direct phone number that you can contact as well. So if you Google MAID, British Columbia health authority contacts, like whatever health authority you're in, there will be a phone number that you can contact to speak to them. And in terms of the MAID coordination centers, we're all different. So in Fraser Health, we have social workers and nurses. Sometimes they are only nurses that are working in a coordination center, and sometimes social workers. So we do work together in that.
Okay, thank you. Shelley, and the same question for you in Ontario. How could somebody get connected with a social worker if they're not already in that hospital setting?
Yeah, so they have a couple of options. I mean, you can call, let's say, the Ontario Health at Home, which is our home care. They have case managers there, and they also have social workers through like another agency that is OHIP funded. So they can access social worker that way, or they can call any community mental health clinic. Let's say even Center for Addiction and Mental Health, they can, they will have a roster of social workers available. The other option is also calling our College of Social Work, College of Social Work and Social Service Workers in Ontario, and both they can probably provide both private and publicly funded social workers in the area. And I believe also even public health, if you call them, they may have rosters of what's available in the community.
Okay, thank you so much. And thanks, audience member, for that question. We have just a few more to go here. This audience member is curious, and again, you can speak to sort of the provincial differences, but are home visits possible? So I think we think of social workers as appointments or having them in hospital or visiting them at an agency location, but are home visits possible with social workers?
I can, oh, go ahead.
Oh, sorry. I could just say if you're already on the home care program, or if you're not, again, it is an OHIP funded a community program or health program where you can access social work from there, as aforementioned, and they would come to the house. Otherwise, we have an ARCS program, which is access to referrals in the community. They're not social workers per se, they're peer workers, or support workers. They could actually come to the home as well, or even meet you in coffee shops. Yeah.
Thank you. Courtney?
Yeah, I was just going to add to that. It really depends on the kind of support you're wanting from a social worker. I know we've just been generally speaking around you're not sure where to go and you want to connect with somebody in the community, but it really depends. So, for example, if you are connected to a palliative program here in British Columbia, you'd be connected to a palliative care social worker who would meet you at your home. If you are needing support with mental health or substance use concerns, there may be social work case managers that again can meet you in whatever comfortable environment you feel good about. Or the other piece is if there's a concern for a vulnerable adult, we do have adult guardianship social workers that work in our home health offices, and they do home visits as well. So they would be the ones to support with leading an investigation if there is concerns about abuse or neglect with a vulnerable adult. I know that's not really the focus of this presentation, but they are significant in the community as well.
Yeah, absolutely. Thank you for sharing that support. And Annette, same question. Are home visits for social workers possible, or not, maybe not necessarily home visits, but out of clinic visits?
Sure. So I'm currently I am one social worker for the province. We have one central health authority. And so there is a second social worker, but she is not working at the moment. And so I conduct a lot of Zoom meetings because of equality of access. It's really difficult for me to do home visits, although I have done home visits in certain circumstances. So sometimes I'll do a home visit when communication is a difficulty and people need me to be there, be present. If there's some sort of communication problem, if there is some conflict within the family, I've gone with assessors to help with assessments and or provisions, so that I can be there for the family while the assessor and provider is there for the person who is dying that day with MAID. So those are some exceptional circumstances where I just go and I make myself available. However, being the one social worker and thinking, okay, there needs to be some equality of access here, I can't always do that. I have been from Cape Breton to Yarmouth in Nova Scotia in exceptional circumstances, but generally I'm a virtual assistant in that way.
Okay. Thank you. Thank you so much, everybody. And thanks to the audience member for that question. So unfortunately, we are out of time for today. So I really want to thank our panel for their insights, their expertise, and their time. Thank you to our audience members for joining us. And as mentioned previously, the session is recorded, so you're more than welcome to revisit it on our website when you're next available. And finally, we hope you find this webinar worthwhile. Thanks to the generosity of our supporters, we can provide webinars like this and all of our other quality and compassionate services 100% free of charge to people across Canada. So with that in mind, we ask that you consider paying it forward and empowering us to continue the work we do by making a donation today. We've included a link in the chat for anybody who is interested. But outside of that, thanks again to our panel and thanks to our audience for joining us. That brings us to our conclusion for the webinar today.
Thank you so much for having us, Amanda, and thank you so much for being here, everybody.
Thank
Yes.
you.
Yes,
And
thank you. It's been an honor.
yeah,
Wonderful.
especially big thanks to Dying with Dignity Canada, who supports our folks who are, seeking some independence and some freedom around their end of life choices.
Oh, well, thank you so much. Likewise for all of the support that you provide to people every day. I think I've definitely got a more expanded understanding of just how much work and responsibilities can be placed on social workers' shoulders. So thank you so much for your service. Okay, that's it for today, everyone. Thank you so much for joining us and take care. Bye-bye.